Good morning, everybody. I'd like to call this meeting of the study committee on PANDAS to order. I feel like I'm in a hole right now. I usually have cushions to sit on. And I told Lynn, that my secretary, she didn't really need to bring them over, but I think I made a mistake. I hope everybody's had a chance to get settled from their morning drive to the Capitol. If you thought it was bad now, you should come when we're in session. And add about a 45 minutes to an hour to the drive and time trying to find a place to park and get into the Capitol. I'm going to let everybody on the committee introduce themselves and tell us where they work. I will start with myself and then I'll go to my left. I'm Representative Sharon Cooper. I do chair the Health Committee. I am a nurse with a master's degree by profession, and my husband was a family practitioner, and I am interested in all things patient care related. And the Health Committee, although it's not written in stone, a health bill can be put in any committee, just like any other bill. But most bills in the Georgia House that relate to health in any way do come through the Health Committee. We've had some funny ones that have been put other places, like the smoking bill. Years and years ago, it used to never come to my committee, and then all of a sudden one morning, it was assigned to my committee. And people came talking to me, and I'm going, wait a minute, that's the wrong committee. It always goes to agriculture. And the people said, no, you got the study committee. And it was an indication that it was time for us to do something about it. So it's sort of funny how it works. So in anticipation that as we go forward, if there's any legislation about PANDAS, that it would come to the Health Committee is part of the background that we established this study committee on PANDAS, so we could learn more about this new phenomena. At least it is new to us, and I think to a lot of people that not understanding about it. So with that, welcome, and if you will introduce yourself, Doctor.
I'm Dr. van Esenwein. My students call me Dr. Silke because that's
Silke?
easier. I am a health policy professor at Emory. I actually have a little bit of different training. I have actually training as a neuroscientist, neuroendocrinology, so behavioral neuroendocrinology and brain development, but now I do health services research, mostly studying mental health and reproductive health. And I'm here as the public health practitioner.
And Leo,
Yes, I'm Leo Chansey. I work in the House Budget and Research Office, and I used to serve with Madam Chair on the Health and Human Services Committee, but now I'm over in the Rules Committee, and I will be assisting in the report with any recommendations and any findings we have.
okay.
Hello, my name is Suvrat Bhargave, and I will take the Madam Chair up on having an extra pillow to sit on as well.
Okay.
That would be nice. I am a giant Indian. I'm a child, adolescent, and adult psychiatrist. I practice in the Peachtree City area on the south side of town, and I'm a native of Atlanta as well, born and raised here, and have a real interest in working with families on education, as well as coming up with whatever treatment plan makes sense for them in particular, and I'm honored to be here and give whatever input I can.
Thank you.
I'm Jill Dickerson. I am a pediatrician by training, general pediatrician. I've done a fellowship in special needs, working with kids with autism, ADHD, PANS, PANDAS, and from learning from our families really has opened up a lot of ideas of how chronic and how widespread this actually is. And in our blended practice, we're actually trying to catch the kids on the primary care side before they get to the PANDAS side, but then also educate our community and really advocate for our kids, because at times it's hard to get the treatment that we need in a timely fashion. And I think that's why we're here.
Okay. Thank you. and my colleague, Chairman Smith.
Thank you, Madam Chair. My name is Richard Smith. I'm a chairman of the House Insurance Committee and also chairman of the Special Committee on Access to Quality Health Care, where this study committee went through. I don't know a whole lot about this issue, but everything I read, I don't like. I think there's a way in looking at this, and I may be completely wrong, and I probably shouldn't even be saying this, but I think one of the biggest issues is diagnosis, early diagnosis of this particular issue, because we've, from what I've read, you know, it tracks very closely with strep throat, or in some cases the flu, and so I'm very interested in seeing what we can do about this, because what it appears to be, and like I say, I'm chairman of the House Insurance Committee, that insurance is going to have to play a bigger role in the solution of this problem by paying for antibiotics a little bit longer. So, you know, this is why I'm here, and I'm really interested in trying to figure out what we can do and what we can do better. Thank you.
So, thank you very much. We sort of have a relaxed atmosphere when we do study committee, so anytime, and I will ask each person that's presenting whether they want questions while they're presenting or they'd rather wait till the end, if they don't mind taking questions during it. Just signal to myself or Leo that you want to say something. We'll turn your mic on and you'll be able to answer your questions. If they'd rather us wait till the end, then we'll have time at the end to answer questions. And I certainly want the professionals. Richard and I are pretty good legislators, but we are not experts. Oh, well, yeah, for both of us, that's sure, isn't it, Richard? It depends on whether they like what we're doing or not. But we certainly want to call upon your expertise. That's why we've asked you to give up your time. Representative Bennett, you are coming in. This is Representative Bennett's study committee. She is the author of the study committee. And you are here just in time to introduce yourself. Good morning. And give us a little bit, you know, about what you do for a living, your normal living. So,
normal. Good morning, everyone. Good morning, everyone. I am Karen Bennett. I hold a doctorate in physical therapy. I've practiced for almost 40 years now. Particularly the last 20 years have been with peds exclusively. And I've worked with families, and I have I've met members of the organization with children who have PANS and PANDAS, and it did touch my heart, much as sickle cell has done. And so I wanted to see what could be done about this to make sure that the families and the children with special needs have the resources that they need. So it's a blessing and an honor for me to serve here. Thank you, Madam Chair.
Okay, I understand that we have a video. It's who is running the video, or it's just us. There's no comment about it or anything. Just want to show the video first. Okay, fine. All right.
I would liken it mostly to an abduction. Something came in the window and stole our child and left behind this shell. Our kid is gone. Like,
12-year-old Parker's brain
Get away! Get away!
is
Get
under
away!
attack.
Get away!
Mysterious outbursts that look like mental illness. His parents desperate for answers.
It's okay, Parker, we got you.
Recording these horrifying moments, hoping that someone might know what's wrong and how to stop it.
behave yourself.
Strep in the wrong kid results in the wrong kind of immune response that impacts the brain and gives rise to behavioral symptoms.
Alexia Bear got strep throat for the first time when she was 4 years old. But just days after treatment, her mom Vanessa says she changed from a well-behaved, happy child to this.
Telling mommy to shut up is not acceptable.
Shut up, shut up, shut up. I'm gonna kill you.
He was a completely different kid. It was looking at a different kid in the same body.
That they could conceive of the possibility that he was not like that 2 weeks ago.
It's like a seizure. It's like watching your child be attacked by a ghost. It's the most out of the blue, random, intense overtaking that you could ever imagine. I don't really know what to relate it to.
Most often suggest that it is a psychiatric problem and have the child pretty immediately seen by a psychiatrist. Like, it doesn't occur to them that this could be a physical problem.
We then saw a psychiatrist who put me on different SSRIs, antipsychotics, Prozac, Celexa, Cymbalta, Lyrica, benzos, Ativan, lorazepam. And I would always ask my mom or my doctors, like, when's it going to kick in? When's it going to work?
It's like he's looking up at me in desperation, like, Grandma, I don't understand this. Please make this stop.
Logan had elevated blood titers suggestive of a strep infection. He also had all of the acute markers associated with PANDAS in terms of his clinical picture. In that scenario, to reach for an SSRI first, in my mind, is bad medicine.
Almost exactly 5.5 weeks into Logan's, I'm calling it remission because I don't know what else to call it. He had his problems for 9 months, and then Logan was 90% back.
I would say the most stressful thing for our marriage, though, has been the financial impact.
I really feel like the situation with the insurance companies, it's kind of a war of attrition. It seems like, at least through our eyes, that they delay the process. They ask you for more documents, you send them, they sit, they ask you for more documents, and they repeat this over and over again. And then eventually you get a denial.
We're in a situation where young children are afflicted by a disease, and insurance companies don't want to pay for the treatment.
Completely gone. She looked like our daughter, but she was nothing like the kid she had been just a week ago. You can't fathom putting your 5-year-old in a psychiatric institution.
We had a team of specialists all advocating that this was the best treatment choice for our daughter, and the insurance company said no.
Let's look at IVIG. So I'm looking at a treatment protocol and procedure that is expensive. But if it works, how can we deny it? And ultimately, what's the long-term cost? So if I look at a young child, a 7 or an 8-year-old, who's developed obsessive compulsive disorder, who's not eating, who has all sorts of other psychiatric or neuropsychiatric symptoms that are going to continue on and on and on, what are we going to pay in the long run?
How can you look at a child that is in this state and say, I'm sorry, I can't help you?
Introduce yourself and give us a little bit of your background.
Good morning. I'm Dr. Susan Sweeto. I'm currently an emeritus scientist at the NIH as I retired in the spring, but I still have an appointment there in developmental and behavioral pediatrics. My training was in pediatrics at Children's Memorial in Chicago, and I came to the NIH in 1986 expecting to go back out and do adolescent medicine, but was working with Dr. Judy Rappaport on her studies of obsessive compulsive disorder. And my partner Henrietta Leonard and I stumbled across some old literature that actually led to the rediscovery of the PANDAS phenomenon. That's what I'm going to share with you this morning. I was asked to just sort of give you a 35,000-foot overview. I do welcome questions at any point during the presentation, and in fact, if we don't finish it, it's fine. Because I'm going to give you the sort of the punchline at the beginning, and that's what Dr. Dickerson already said, and that is that early treatment really is powerful. So your comments representative about if we could just get the diagnosis, get awareness campaigns, early recognition, it could make a huge, huge difference. I had the privilege of caring by phone for a 5-year-old here in Georgia many years ago now, who the grandmother had asked us to talk with the mom, and I did, and it sounded like a classic PANDAS. We had her go to the pediatrician, and with our encouragement, the throat culture was done, was positive, the child got treated, and the symptoms resolved within 4 days. You contrast that with some of the things we saw in the movies where the children have been in psych hospitals for months before any interventions are done. And there's really, in my mind, it's sort of a no-brainer, as Dr. Ashley says in the video.
Okay. Chairman Smith, do you have a question to start off?
Yes, ma'am.
Okay.
In regard to the comment that you made that after 4 days, the child was basically back to normal. How difficult is it for a physician to identify this issue? Because and I like to study up on these things as much as I can, it's not a very common disease.
No.
So if it's not very common, then how difficult is it to diagnose? I know you mentioned the blood test and all this to find out, if the child had strep and this kind of stuff. Because I'm very interested. I've got a 6-year-old granddaughter. And how did it get cured so fast in 4 days?
So we'll get into that a little bit through the presentation, but the short answer to the question is that while the group A strep, the same thing that gives you a strep throat, scarlet fever, the bug we all know and most children get a couple of times every winter, certain strains of that, about 6 to 8 of the 120 different strains, were known to be rheumatogenic, and that is they could cause rheumatic fever. So there's something on the cell wall of that strep that looks like it's human host. And I usually equate it to Harry Potter's invisibility cloak, where he sort of puts it on, and Harry and Hermione and Ron could go off and do their adventures, but so that those of us watching the movie knew where they were, right? The edge of the invisibility cloak was always up. It's exactly the same thing with the strep. The strep puts proteins and antigens on its cell wall that make it look like it's human host so it can hide from the immune system, but the immune system eventually recognizes it. Those antibodies then cross-react with the child's own tissues. In the case of heart disease, against myosin and other proteins in the heart muscle. Arthritis, it's against the joint. And in Sydenham, chorea, and PANDAS, we now have beautiful evidence that it's against components of the neuronal cells within the basal ganglia, within the base of the brain. You wipe out the strep, and those antibodies will disappear. In the case of an acute onset, acute recognition, an acute treatment, as soon as you treat the strep, the antibodies disappear because the child's body knows that those antibodies don't belong there. In prolonged cases, it takes much more time, and that's where we come asking you for help with things like IVIG, even plasmapheresis and rituximab for the children who are so severely affected that they have stopped eating or they are trying to jump out of a moving car because they have such strong suicidal ideation. And perhaps the child psychiatrist can speak more to some of the profoundly ill children. But I want to just preface my remarks by saying the movie that you saw obviously shows you some of the more extremely affected children, but it isn't actually an uncommon illness. In the Washington, D.C. area, we did an informal poll and found out that at the CVS Minute clinics, in certain towns where there were actually these rheumatogenic strains, half of the throat cultures were being done for behavioral indications. So the mom would be bringing it in and say, My child is anxious. My child is suddenly flipping out and is having these rage attacks. And she's been such a calm, easygoing child up until this point. The nurse practitioner did a throat culture and treated appropriately when it was positive for strep. For the first 20 years, that's all I asked was, if you find strep, treat it. Don't give antibiotics unnecessarily. We don't want to make, be poor stewards of antimicrobials. But in the last 10 years, as we've really honed in on some of the things we'll talk about in a moment in terms of the cause and the mechanism of disease in this process, we kind of know from the point the strep enters the body to the point where the symptoms are being manifest, almost every step of what's happening. And the latest work out of Columbia is showing that the blood-brain barrier is disrupted in a way that actually makes this a self-perpetuating process at the point that the strep has now been cleared from the body and you're left with this post-infectious autoimmune process. So that's a great introduction, actually, to just kind of dive in. I do want to thank the members of the consortium, who are the people in the last 10 years who've really done this work. We now have representatives at 29 institutions across the country, from New England to California, and it's their clinical observations that are really helping us to understand this. I don't think I have to educate the committee. It sounds like you guys already know this, so we'll just skip very quickly to the final two. The true difference between PANS, Pediatric Acute-Onset Neuropsychiatric Syndrome, and PANDAS, Pediatric Autoimmune Neuropsychiatric Disorder, is actually in those two words. A syndrome is just a collection of symptoms like depression or dementia. And in dementia, you want to get to the disorder. It's either Niemann-Pick or it's Alzheimer's, or you try to find what the cause is. So PANDAS is a subclass of the children who have an abrupt onset. As you mentioned, influenza can do it. If it was caused by flu, it wouldn't be PANDAS. It would just be PANS provoked by influenza. The clinical criteria define both the syndrome, both the clinical presentation, but they also define the disorder. And the research criteria for PANDAS were actually published now more than 20 years ago in the American Journal of Psychiatry, based on our experience with a couple of hundred children that we were following in a drug trial for just non-specific obsessive compulsive disorder. And what we had found in that cohort of children was that somewhere between 1/4 and 1/3 had an abrupt onset of symptoms. They had these fine choreiform movements of their fingers. We call them choreiform because they are involuntary movements that get worse when you are asked to do a voluntary motion, but they're not actually chorea. They're not Sydenham's chorea, and I'll show you a better video of that in a moment. The temporal relationship between symptoms and the group A strep, we made it purposefully vague in the beginning, mostly because in Sydenham chorea there could be a 4 to 9 month lag between the inciting strep infection and the onset of the chorea and the emotional lability and the other symptoms that we diagnose now as rheumatic neurologic complications. And the thinking is that the antibodies, those cross-reactive antibodies, are necessary for that process but not sufficient. And that may very well explain why, with strep being so incredibly common, why is PANDAS and PANS relatively rare. The differences between PANDAS and other presentations of childhood onset OCD: our children are very young. They are the 6 to 8-year-olds in kindergarten and first grade, or now that children are in daycare and preschool, much younger. We're actually seeing cases as young as 3 or 4. There have been a number of cases now described in which the child was thought to actually have autism because they so socially isolated themselves. They had such a severe developmental regression. They were thought to have a form of regressive autism. And in one case, they went for several years before the appropriate diagnosis was made, and that child recovered much of the lost skills. In other cases, it is just a red herring where the child actually has what we would consider a classic diagnosis of autism, and the parents have read about PANS, PANDAS, and we chase that for a while and come to the conclusion that that's not appropriate. In non-PANDAS childhood OCD, there is a waxing and waning of severity. Times of stress are going to make symptoms worse. times of distraction, so the child doesn't have any need to ritualize during the day when they're at school with their friends and family, and they get home and everything falls apart and they spend 4, 5, 6 hours doing their rituals. That is classic for obsessive compulsive disorder, not just in children, but in adults as well. Nobody quite understands that, except that perhaps some of the basal ganglia gatekeeping functions just can't traffic with attending to obsessions as well as trying to attend to these other intervening causes. We used to suggest that they take the Disney World cure because your symptoms would always disappear for the first 2 or 3 days in Florida, but they would find you and come back. So that didn't actually work. And the treatments are the same and yet different. I'm going to just focus for just a few minutes at the end on the treatment of PANS PANDAS. I say PANS PANDAS. All of our research information comes from the PANDAS cohort. It was a 2.5-year process of the consortium, the 29 members plus people pulled in from all the subspecialties represented to really finally make a determination that yes, a month of antibiotics is appropriate even if you don't have a positive throat culture because of the occult sinusitis. The use of SSRIs, antipsychotics, other psychiatric medications is entirely appropriate to relieve the symptoms of the children. The difference comes in whether or not a child with non-PANDAS OCD would benefit from any of those things. And so it really comes down to the acuity of onset. And if I were talking to the parents, I would be emphasizing the fact that you don't want to sort of push for a PANS PANDAS diagnosis if that's not what your child has, because it too can waste time that could be better spent getting the appropriate treatment.
Dr. Sweeto, just stop just a minute.
Yes.
Chairman Smith. Sorry.
No, please.
You had mentioned 1 month of antibiotic treatment. You had also mentioned that a child would get strep a couple of times a year, and I've heard as many as 4 to 8 times a year. So is there, every time a child gets strep, would you recommend, or the flu, would you recommend a 1 month treatment of antibiotic?
I think it totally depends on the child. So the research criteria for PANDAS require you to have 2 strep-triggered episodes before you call it that, just because of the sort of the math, which our epidemiologists could probably help me with more, but you didn't want it to be a true, completely unrelated event that the child had a strep and they had this behavioral deterioration. So let's consider them to be strep-triggered. But once you got that connection, and particularly now that we have some antibody tests that you can do to see if the child has the circulating antibodies, we advocate for that PANDAS child that they get the acute treatment to eradicate strep, whatever that takes, and we follow the American Academy of Pediatrics Red Book recommendations for eradication of strep from the nasopharynx. And then we put them on prophylaxis. We used to use just penicillin VK, very cheap. The insurance companies wouldn't even care because it literally is a couple of dollars a month. Because the strep is not resistant to penicillin, that should work, except for the fact that with our current microbial climate, almost every child is colonized, if not infected, with bacteria that gobble up the penicillin. They're called penicillinase-producing bacteria, and so PenVK wouldn't be enough, and those children might have to go on azithromycin. But we use prophylaxis just like they do for rheumatic heart disease, where if you have one bout of rheumatic fever, you are on lifelong antibiotic prophylaxis to prevent you from ever getting another strep, in hopes that you won't end up having to have a valve replacement. We don't have to have lifelong for Sydenham chorea or for PANDAS, usually just into the 20s. But I was telling Jessica as we drove over that I just heard this week from a mom whose son is now 33. He was in our Sydenham chorea study, and he had just had an exacerbation of a Sydenham's, was positive for strep. They couldn't eradicate it. What should they do? So it can be a lifelong problem, but in general, it's a short-term issue. And I think just in terms of your committee, sir, the insurance issue for our children is using medical treatments on what are usually considered to be psychiatric illnesses. And that has created a lot of controversy. I mentioned the controversy in my remarks here, but the reality when you were talking about why can't they just make the diagnosis, I think that we as pediatricians have to take a lot of blame for that. We allowed a false controversy to arise, and maybe Dr. Sells can even speak to that point, that if you read the pediatric literature right now, today, if I were reading it, my bias would be that this doesn't exist, or if it did, that it is something that would be better treated by the child psychiatrist. So we have our work to do on that side, and the American Academy of Pediatrics is actually tackling that even as we speak. They're doing the literature review. They're putting together an expert panel and have promised me that there will be, within the next year, a formal statement. Our work started on this, as I mentioned, about 30 years ago, because Dr. Rappaport was looking for a medical model. And Sydenham-Chorea really was the best medical model because it hit exactly the same part of the brain that our PET studies and other imaging studies were showing was problematic in children with obsessive-compulsive disorder. The basal ganglia inflammation in those patients who died, not from the Sydenham, but from the rheumatic heart disease that came at the same time, showed that the inflammation was focused in the caudate, the putamen, the very structures that we knew to be causing obsessive-compulsive symptomatology. This is an example of a child with Sydenham's. I tried to do my puppet dance, and I don't do it very well, so this girl has a particularly severe case. She had to be helped up out of the chair. She could do had no functional ability. If she tried to brush her teeth, she would just flop and flail about. If you watch her, I don't know if you can see her toes curl up with every step that she takes, and if she takes a step, then her arms kind of wiggle and flail about. We spent the 2 weeks she was in the hospital with us, getting her belts and a wheelchair and other things to go back home to Los Angeles. And I'll show you a little bit later. Because she received plasmapheresis in our study, we were able to completely cure her within 2 weeks of her hospitalization. So she went from being unable to get up out of bed by herself, dress herself, feed herself, do anything else, to being completely functional. What you can't see in the video is the fact that she had developed acute obsessive-compulsive symptomatology, and she had very profound fears that something was going to happen to her sister, and she had to do all these checking rituals, which with her Sydenham's was very, very difficult. And she was extremely frustrated because she and her sister didn't get along very well. So the fact that she had to worry about her sister's safety definitely pointed out the irrationality of obsessive-compulsive symptoms. We went back to the old ancient literature, not ancient, but the 1800s. Sir William Osler described perseverativeness of behavior in children with what we now know as Sydenham-Chorea. And in the 1920s, there were a number of beautiful case reports. I highlighted two here. In one of the girls, she became acutely disturbed and excited, tearing at her clothes, threatening suicide. She refused to eat because she thought potatoes were filled with fecal material. The other girl also refused to eat, and for 10 days she had to be tube fed. And to be perfectly honest, we were so focused on obsessive-compulsive disorder that we really missed the anorexia in the Sydenham-Chorea children. When one of my colleagues made that connection, we went back and looked, and indeed 2 of our boys had a very abrupt weight loss, both of them related to body image distortions during the period of their Sydenham-Chorea.
Dr. Sweeto, I have a question.
Yes.
Okay, when I heard you speak several months ago, you're a little bit more in depth with this, which is really good, because we need to know that. But I think I'm lost a little bit.
Okay.
Okay, in PANDAS, are you saying that they get moderate Sydenham-Chorea symptoms? Is that?
So in PANDAS, they get all of the behavioral symptoms. In fact, I think I'm getting there, so we'll skip over these because we already had a good example of this. This is just the proof that strep is causative in PANDAS, and you guys have already I do want to stop on this one, and then I'll get to PANDAS and how we make that diagnosis. Okay, I promise. So the 2 decades of discovery, including antibodies that actually induced cell signaling, so they are biologically active within the basal ganglia. As I mentioned, Jertan Agalyu's most recent study shows that the blood-brain barrier is actually open, allowing these antibodies and activated T cells and other cells that should not be seeing the brain tissue to get in. And those antibodies, when put into a group of mice, induce these backflips, stereotype behaviors, hyperactivity, anxious behaviors. Interestingly, when you take the blood from those mice, transfer it to another group of naive mice, they do exactly the same thing, proving that indeed it is something within the blood. Antibody depletion studies are now showing that indeed it is the antibodies. And the most recent group discovered wasn't just the dopamine D1, D2 tubulin lysogangliosides, but Chris Pittenger and his colleagues at Yale University have shown that one of the histaminergic antigens is recognized, and the beauty of that discovery is that it explains the breadth of symptoms that we see in children with PANDAS. So when you see a child with PANDAS, it's very easy to recognize after you've had your first one. You're sort of like, oh, mom's coming in telling me that the child's been fine, and all of a sudden she can't drop him off at school. That sounds very similar to the child who was easygoing, everything's going fine, and now suddenly they're raging and they refuse to cooperate with anything happening. It's truly in that sudden onset. The decade of controversy started with three neurologists who had a tremendous amount of influence and were very prolific in their editorials. And it really has muddied the waters, because they got funding to do a study that the first hypothesis was to prove that PANDAS didn't exist. You would know that that isn't actually the way science works. So when they came in for their third revision and some pressure, they were able to get funding, but the goal of their study never changed, and not surprisingly, they didn't find it. More importantly is what we talked about earlier, and that's the fact that strep is such a ubiquitous disorder in early childhood. It's been called the occupational disease of the grade school-aged child, and just the fact that that happens so frequently and PANDAS doesn't happen that often is problematic. The neurologists who were anti-PANDAS started, when they couldn't make the argument anymore that this didn't exist, they started saying, oh, well, you're just missing Sydenham chorea. This is not easy to miss, and particularly since we had people from the movement disorder branch of the Neurology Institute at NIH doing our exams, and we were hoping to find Sydenham's because that was not controversial and could be treated. I don't think that's the real problem. A bigger problem is the fact that strep is not the only infection, and we actually knew that from the very beginning. In fact, the very first report written on this phenomenon of acute onset OCD actually had cases that had been triggered by influenza, by chickenpox, as well as by group A strep. We focused on group A strep because we were looking for a medical model, and besides, the pathophysiology is a little bit easier. Subsequently, we've had reports with mycoplasma, H1N1 influenza when we had the bad outbreak a few years ago. It was a terrible time for acute onset behavioral problems. Lyme disease has been anecdotally reported, but I actually don't think the connection is real. Excuse me, and my colleague Brian Fallon at Columbia University is looking at that in his large cohort of patients with Lyme. The pathophysiology of Lyme is much more of a slow moldering disease that you sort of find out a few months or years later that that's what's your problem, and that's not what we're seeing in PANS. So PANS came about frankly, by committee in 2010 in an effort to actually address the controversy. And at that time, the controversy is totally centered on the issue of strep. And why were you giving antibiotics to these kids? So we said, okay, fine, let's take strep off the table. Can we at least get you to recognize and treat these children in an appropriate time? Took out the requirement for 2 episodes before you became suspicious. And really, in this one, focused in on what was the most salient feature of this disorder, and that is the fact that the child not only had OCD or an acute eating restriction, but they also had separation anxiety, emotional lability, all the things you saw in the movie, where the child just suddenly has a dramatic personality change and suddenly is having behavioral problems that are not just present at home, but at school, with friends, and other places. In addition, and this is probably our, we call it pathognomonic, it's the telltale sign that a child has PANS, is urinary frequency urgency or new onset of secondary enuresis. 10-year-old boys who suddenly start having, wetting their pants during the daytime or having nighttime accidents, previously completely toilet trained and dry. If that's happening, the diagnosis of PANS, because it does not happen with anything else. In anxiety disorders, children might worry that they need to go to the bathroom, and so they'll seek the bathroom frequently, but these children are trying to void 20, 30, 40 times an hour, and we think that's because the external sphincter is controlled differently than the internal sphincter, and that they're trying to maintain continence just between sort of that internal sphincter, which is open, and the external sphincter. So all of these symptoms coming on at the same time, in conjunction with significant obsessional worries, compulsive rituals, and usually some form of eating restriction, either because the food's contaminated, like those two Sydenham cases, or because they think they're fat and need to lose weight. We've seen both. And in most children, as you can see, I don't know if you can see it on the bottom, but in most children, they have 5 of those 7 categories come on at the same time. So it literally should not be hard to recognize and diagnose. Typically, though, as you heard in the movie, because pediatric practices are so busy and we have so little time to spend with our patients, if you hear a behavioral symptom as the primary complaint, then the first thing to happen is to get them to a counselor, psychologist, or psychiatrist. So there's a few things that would aid in that diagnosis early on, and one of them is a deterioration in handwriting. If you ask the child to copy a complex figure, they just can't do it at all. Bringing in school journals, you'll see this beautiful sort of boom, fall off when they or their sibling has strep, and then it comes right back up after the strep is gone. They have unusual margin drift. I think it's too pale to see that, but the teacher says, how about starting your sentences at the left margin? Because the child just sort of wanders over. I have my first clock. I haven't had a chance to make it into a slide yet, but we thought that this might be a sign of left-sided neglect, and indeed it is. When we, very few severely ill children, if you ask them to draw a clock, they put all the numbers over on the right side of the clock face. Behavioral regression, this picture looks like it was drawn by a 3, maybe 4-year-old child, or my patients would tell you it looks like Dr. Sweeto drew it, because I have no artistic abilities whatsoever. She was actually 10, and she was quite a good artist when she was healthy. The beautiful thing about this is that she was recognized relatively quickly, got to Dr. Miro Kovacevic in Hinsdale, Illinois, was treated with IVIG in June, and by September was back to her pre-illness baseline. We also were able to document that it is indeed in the basal ganglia, and that the dysfunction in Sydenham, chorea, and PANDAS is comparable, just as the antibodies were comparable. Not identical, and there are certain things in Sydenham's that are more profoundly impacted, certainly giving rise to the choreoathetoid movements. But in PANDAS, there are other things that are much more impacted than they are in Sydenham's, and that includes the cognitive function, so that our children will have brain fog and will have actually amnesia for the acute episode, which in some children is a good and probably healthy thing for them not to remember. Unfortunately, their parents remember it quite vividly and not fondly at all. So in 2015, we gathered together actually to address the chair's concerns about sort of how we're going to make this diagnosis, how are we going to help pediatricians to go after this? Is there a blood test? Is there anything else? And it really came down to, it's unfortunately a multidisciplinary intensive evaluation if the child has been ill for anything more than a few days. So if a pediatrician sees it in the office, within that first few days, it's going to go the way the phone call and the antibiotic administration for the acute strep do. But more typically, the strep is already gone, and you're left with this behavioral conundrum. And this is a relatively lengthy document, but it's been out, and the SEPA and other places have made it available on the website. So that lengthy document actually is boiled down to just a one-page algorithm on the PANDAS Physician Network website, and that you can just follow, if this, then that, if this, then that, and it's easy to do, and I think it's now a matter of getting the word out to people. The second question was, what difference does it make, right? If you diagnose this, strep is gone, what are you going to treat? And as I mentioned, we had very little experience with PANDAS. It had only been described in 2012, and we were meeting in 2015. So 3 years after the description of a syndrome, you're not going to have enough clinical information to base recommendations on. But we were able to extrapolate from our experiences with the PANDAS patients, particularly those who had recrudescences not related to strep, related to influenza or other viral infections, and came up with a three-legged stool, three-pronged approach, the mainstay of which is eradication of the infection. And the reason we use a month and the reason we are advocating a month of antibiotics is it isn't just the group A strep in the oropharynx, it gets you strep throat. You actually get it in the nasopharynx and the sinuses are particularly difficult to eradicate. So a month of antibiotics in 2 different studies done by Tanya Murphy has documented a great improvement, and Dr. Fernanda Falcini from Florence, that's a lot of F's, but Dr. Falcini has just published a paper in over 200 children in Italy in whom she used just PEN-VK, and more than 85% of them were improved back to baseline at the end of a year. So we know that antibiotic administration alone is often sufficient for these children. If they have more symptoms, I equate it to the difference between a sinus infection and pneumonia. If you have a child with pneumonia, particularly if that child has a baseline problem with asthma, you're going to treat the asthma, you're going to treat the pneumonia with antibiotics, but you're also going to try and provide symptomatic relief with inhalers or with antitussive agents. So we use antibiotics to get rid of the infection completely, sometimes to prophylax, to prevent future infections, prevent that child from having future episodes. And then we depend on immune therapies to get that child back to baseline. And again, if this is like pneumonia, because it's like rheumatic fever, we know it's a temporary loss of tolerance, that the child's immune system just gets mixed up. It's not actually autoinflammatory like lupus or some of the diseases that adults get, even rheumatoid arthritis. This is just a temporary loss of tolerance, and so what you have to do is restore the baseline for that child. You might hear from some of the parents that I can say, all you have to do is just restore that baseline. That is a bit complex. And you might have to use a combination of every weapon we have in our arsenal: non-steroidal anti-inflammatories, steroids, intravenous immunoglobulin, therapeutic plasmapheresis, and other medications. And I don't know in terms of...
I have a question.
Yes, ma'am.
Go ahead. So you're saying we're turning them back to baseline. So can we expect, if they're treated correctly, that they're all returning to baseline?
Yes.
Are they regaining all of their cognitive function and
yes.
behavioral?
They retain, I said yes because they regain 99% of them. Mm-hmm. We can find it with some neuropsychological tests. There appear to be some lasting visual spatial skills deficits, but frankly, with GPS, those are really not impairing in any way anymore. It used to be when we would see our adult patients that they would have trouble navigating through the NIH maze, and we'd have to meet them at the front door and walk them back because otherwise they'd wander the building for hours. But now I think it's really not a problem. And even children who've been sick for a number of years before they get appropriate treatment will come very far back to baseline. And I've had, again, because I was at the NIH so long, my kids that were in my first treatment study are now all in their late 20s to mid 30s, and they are, the number who still have obsessive compulsive disorder is actually less than the population rates. So it is a reasonable and achievable goal.
Mm-hmm. Is it easier to get them back when you get
early?
Diagnosed early?
Absolutely, absolutely. And I think, you know, if I could push for, in addition to making sure we can pay for the treatment promptly for children who are severely affected, I think the other thing that Virginia is trying to do, we're working on a public education campaign just to get the word out quickly enough. And as I mentioned already, the American Academy of Pediatrics has to do their job to educate the pediatricians as well. Here's the kind of change you can see with the IVIG, intravenous immunoglobulin, in a very severely ill group of children. reduced symptoms by 45% within the first month. Just for comparison, a successful drug treatment trial would improve symptoms about 23% over the course of 12 to 16 weeks. So very marked improvement in the IVIG, even more profound in the plasmapheresis group. And in part is because plasmapheresis not only pulls those antibodies off, but it resets the cytokine-chemokine balance, and it's sort of the nuclear bomb of treating this disorder. It is quite effective, but it's unfortunately not available at very many places across the United States. What you're looking at here is on the left, I can't see it, so maybe you can't either, but there's a little white line around the structure right next to the butterfly. The butterfly is the ventricles, and the structure to the left of it is the head of the caudate nucleus. That's the basal ganglia that I keep talking about. At baseline, it was 20% enlarged for his age, sex, and weight. Following successful treatment with plasmapheresis, it had normalized. He went from having literally every waking moment attending to an obsessional thought or performing a compulsive ritual. He was a gymnast, and he had symmetry concerns, so he was trying to get the right side of his body to be exactly the same as the left side, which is clearly impossible. On top of it, he had developed eating restrictions, at first because he was a gymnast and was taught to eat healthy, and then fat became poison to him, and soon carbs did as well. And if you don't eat fat and you don't eat carbs and you don't like protein, there's not a lot left. So he went from very debilitated to completely well within 2 weeks.
Okay, Dr. Dickerson?
Yes.
I have a question. Is there a standard, like standardized sizes? Because when I order an MRI and I ask our local experts to give me the size of the basal ganglia because I need that, I never get it.
And you probably won't. There are standards, but it really requires very complex math and comparison. And so the larger study that he was part of, he was the only one who had anything more than 5% difference. And you really can't tell that, because if you put a child into the scanner today and they drink a lot and come in tomorrow, they might actually have a 5% difference in their size. So looking at the size isn't as helpful. We're actually, the group at Delaware is currently using co-registered MRI and PET. So the PET imaging can show the inflammation in the basal ganglia, but because it involves radioactivity, it's not a study we do in kids very often.
What about SPECT?
SPECT probably won't give you the resolution, the spatial resolution that you need. I know there's a SPECT group that advertises they can do SPECT studies for PANDAS. They also say they can do them for ADHD, and it's frankly a waste of money. So I don't think SPECT is there yet.
Okay, thank you.
Functional MRI, we haven't found one yet. Probably the closest thing would be MEG. I don't know if you have magnetoencephalography here, or just plain old regular EEGs. I think I took that out because I didn't want to focus on the autoimmune encephalitis component, but 17 to 20% of the children have abnormalities on EEG, slow spike waves, and the best study, sort of the most frequently positive study in this cohort of children, is a polysomnography, a sleep study with a neurologic reading, because 86% of the children have evidence of REM sleep disturbances. So they fail to establish atony during REM sleep. They continue to move about, and about 25% of them will actually meet criteria for REM behavior disorder. So for those of you who aren't neuroscientists, a sleep study usually is done for apnea in children because their tonsils are too big and they snore and they aren't getting their sleep. And in adults, it's because we are snoring and stopping breathing in the middle of the night. The sleep apnea is not a problem for this cohort of children. But what they have instead is during REM sleep, your rapid eye movement sleep, the only thing that's supposed to be moving is your eyes. And it's been theorized it's because you're watching your dreams and you don't want to act out your dreams. If you do, they put you on the news as one of the side effects of the sleep medicines. But in these patients, like Parkinson's disease patients who've had destruction of their caudate, they don't have appropriate inhibition of motor and sensory function during the REM sleep. So if we did sleep studies in all of them, again, an insurance issue, because ordering the sleep study with neurologic reads is something that insurance companies, at least in my state, like to deny. Well, we saw our patient C at baseline, and I told you that she got plasmapheresis. She came to us, she couldn't do any of her ADLs. I kind of already gave you the punchline, but here she is 2 weeks after her treatment. She had absolutely no medications, and she is completely fine. She was back in school, she was functioning, all of her OCD symptoms were gone, her emotional ability, her anxiety, everything was perfect, except for the fact that she came from Compton, but that was a different issue that I wasn't able to solve. So I know it works even in profoundly ill children. If you are bad enough to come to the NIH from California, you're a very sick child, and we've been able to treat all of those. My colleagues who are in practice, like Miro Kovacevic in Illinois, has more than an 80% long-term cure rate with the use of IVIG. And we're not talking IVIG for months or years. We're talking, for most children, one course of treatment. Children who've been sick longer may need 2, 3, even extended courses, and we're now able to look more carefully at what's coming in at baseline. And if that child is severely depleted in their immunoglobulins at baseline, then we actually sign them up for a longer course of treatment, because you have to replace what's been used and is gone. While you're doing that, you have to treat the symptoms. And I get really upset with parents who come to me and I'm telling them that they need an SSRI or other anxiolytic medication, and they're saying, no, I just want the antibiotics. And then we go into the discussion of, if you had a broken arm, would you let it heal on its own, or would you go ahead and put the cast on so that you didn't have to have pain every time you tried to move that arm? This is just human health care, in my opinion. It's not necessarily going to shorten the course of illness, although, to be perfectly honest, when we claimed our 85% success rates at 1 year, it was because more than half of the children were on SSRIs. So we do a full court press, do everything in our power to get that child back to baseline, let them grow and develop at that baseline. And my personal rule is, when they've been symptom-free for a year, we start weaning off the SSRIs, the other medications that we're using, see how that goes. If that goes well, still no symptoms, then 6 months or so after that is all out of their system and they're still doing extraordinarily well, we might talk about stopping the antibiotics. But it's a semi-acute illness. The child may well be sick for several months or even a few years, but they should recover completely and fully and go on to lead very productive lives. It impacts the school system tremendously, and it's a really difficult one to manage in the school, because traditional IEPs and 501s just don't work, because those require you to sort of set something up at the beginning of the school year and then stick with that plan. These children's symptoms are changing all the time. So Dr. Doran has written a book with the help of Dr. Tienemann at Stanford. There are 2 other books out there, all of which have some really helpful hints, and I urge you to kind of check those out. But it isn't just my belief, it is now a known fact that both PANS and PANDAS are treatable, preventable mental illnesses, and I think it would just be a huge victory for Georgia to be one of the states to be on top of this. Thank you.
Just a moment. I have a question.
Yes.
Okay. You called it a mental illness. I understand that it affects the brain. I'm not sure that we should call it a mental illness.
Okay, especially in Georgia.
Well, there still, unfortunately, is a stigma attached to mental illness, and if we are saying that it is strep-based, it seems like it's more just a different illness.
Yeah.
I guess I'm worried about things get stereotyped, and mental health is one of my big areas of interest and expertise, and I just don't want something that's caused by strep to label somebody as being mentally ill.
I actually hear you quite clearly, and I will retract the mental illness out of respect for the place where most of society is. I think coming to the NIMH as a pediatrician, I always envision being the square peg in the round hole. But in actual fact, it truly was the partnership between Henry, who's a child psychiatrist, and me with my pediatric developmental training that led to this. And what we both came to understand quite clearly was that mental illness in the vast majority of children is a biological illness equivalent to pneumonia. ADHD to me is the diabetes of the brain, right? That you just need a touch of Ritalin and you're fine. Well, you wouldn't deny a child insulin, but many parents feel comfortable or feel uncomfortable giving the Ritalin to their child. So the more we can make that marriage, the happier I'll be. But I hear you. Let's fight the first fight first.
Well, and didn't Freud say something about, in the end, we would find that all mental illness had a biological component to it, I think, in some of his writing, that but nobody wanted to pay attention to because he was writing about sex.
And in fact, his study on the Rat Man, his famous OCD study, he concluded this was not something he was going to treat with psychotherapy.
Okay, and the other thing, I'm still confused, and it's my shortcoming, Pammy. When does PANS become PANDA?
When you can prove that strep has been the etiologic agent. Otherwise, you don't have to care.
Okay.
So the bottom line is we now are calling it PANS/PANDAS. I think probably in the next iteration it's going to go just to be PANS. And if we ever get into DSM, it will be PANS. The ICD-11 was written several years ago, so in ICD-11, PANDAS is the diagnostic code. I think that in terms of trying to help children, it would probably need to go back to its first name, which is Anti-Neuronal Antibody-Mediated Neuropsychiatric Disorders of Childhood. No? Talk about stigma. That would really... Thank you.
Okay, well, I'm going to go in order of questions, and we have a lot for you now. Okay, Richard.
Okay, thank you, ma'am. And I want to agree with you that this is a disease from the way I look at it. I have two questions, if you don't mind. Does this particular disease lead to any other issues? Is it a precursor to anything else?
Absolutely. Untreated PANDAS is a leading cause of adult depression, obsessive compulsive disorder, and anxiety disorders. And obsessive compulsive disorder is currently third or fifth leading cause of disability worldwide. It's relatively unrecognized because the rational irrationality of symptoms in obsessive compulsive disorder, the patients truly recognize their problems are crazy, and so they hide them as long as they can. They even in therapy, it can be 10 years between beginning to see a therapist and finally divulging that they have OCD symptomatology. So that leading cause of impairment worldwide, we have been able to look at our clinical studies in comparison with a large epidemiologic study that was done in the 80s and show that about a quarter of adult OCD would be preventable if we could recognize and treat this PANS in early childhood.
Okay, second question. And this has nothing to do with all the stuff you've been talking about.
Okay.
As legislators, what can we do in order to address this issue? Give me the top 5 things that we could do in order to help address this issue.
I can share with you the experiences in Arizona, which was quite successful, and it was because of their state legislature. What they did was they worked with the Department of Public Health to have an education campaign for the physicians through the Department of Public Health that had been mandated by their state legislature. Got the symptoms out, got the treatment, the diagnostic algorithm went out to pediatricians, actually to family practitioners, emergency room physicians. It went out to everybody through the Department of Public Health. The second thing is that the second line, not responders, but recognizers would be school nurses, school personnel, psychologists, and others. They are in some ways also under the auspices of the legislature, so that outreach and education campaign would be extremely helpful. Arizona did that, and through again, through the Department of Public Health with the Department of Education partnering. Virginia, the council that I'm sitting on, we're actually working through the State School Nurses Association, the state school psychologists, and through the Department of Education directly for that one. Then the third piece would be, frankly, to address the insurance problems. And I don't know,
okay, now when you mention insurance problems, what are they? The denials, or not paying for a month, or not? You know, okay.
It's not as much the paying for maybe Dr. Dickinson even wants to address this, but the month of antibiotics is rarely a problem because they're cheap enough that they can get them. Do you want to come up and help me?
Oh, you can get those at Publix for free.
You get them, or you can get them at Publix for free, or at other places. So it's not that. It's actually the extended medical workup, trying to get a sleep study, and getting it in a timely fashion. When we talk about trying to get IVIG, we currently have two problems. First, intravenous immunoglobulin is in extreme shortage supply. And so our children have to kind of go to the end of the line because it's not going to make a difference between them being alive tomorrow or not. We haven't published that because I don't want them to be at the end of the line forever, but we are trying to be good citizens and recognize that IVIG for PANDAS is an option. It's not the only option like it might be for other diseases. But let's say that IVIG comes back into ready supply, the insurance companies will still deny. And as you've heard, early prompt treatment is cheaper, more effective, and saves the child from that suffering, but the families are going back and forth with the insurance companies. And the physicians, nurse practitioners and other practitioners who are trying to get it for their patient are just sort of beating their head against the wall. And I think that comes down to the whole stigma issue and how are you doing parity for mental illness versus physical. And so we do encourage, whenever possible, to get hard data. Lab abnormalities, sleep study abnormalities, or other things that the IVIG can be useful. If I could digress for 1 minute, we have to be a little careful with, I should let you speak to this, sir, but the insurance companies traditionally have gotten quite good at not paying. And in Illinois, we thought we had the problem licked. They actually had state legislature, not mandated, but encouraged funding of PANS care. And there was one of the diagnostic criteria for PANS is that the symptoms cannot be better explained by another disorder. And one of the examples given is autoimmune encephalitis. We have that in there because anti-NMDA, GAD, some of the other forms of autoimmune encephalitis can mimic PANS-PANDAS. We wanted people to test for those, rule those out before they gave a diagnosis of PANS.
Can I make a comment on that? With the insurance.
Yes.
There are several types, but there are two really big ones. One is called an ERISA plan. Those are federally regulated. Now, with the people in Georgia who have insurance, about 74 or 75% are under an ERISA plan. Then you have Medicaid and Medicare, okay? That only leaves you about 10 to 12% of the population that we can have influence over as far as mandates or any of this kind of stuff. Now, 10% of the population's 1 million people, so it's not a small population, but you know that 74 or 75%
is not touchable.
It's not touchable.
Okay.
And the courts have told us that.
Okay.
So whatever we come up with, yes, it can be mandated for small business and individuals. Now, every time you add a mandate, you increase the cost of the premiums. And at what point are the premiums going to go so high that the employee can no longer cover their employees? And that has happened because we have so many mandates. And the same thing with individuals. I know right now individuals who are paying $2,800 a month premiums. I don't see how they afford it. And some of these people have $8,000 to $10,000 deductibles. So you know, there's a lot of issues in there. But I think as far as the insurance companies, you know, back in the 80s, we probably had 200 companies here in Georgia writing insurance. We've probably got 5 or 6 now.
Really?
but I think we can get them to be more responsive to this particular issue. I can call them in. We'll have a nice long sit down. So I think we.
So I think one of the things maybe we can help get for you is some of the financial stats, because my interactions with insurance companies is they are human beings, but they have a bottom line that they have to meet, and
But they also have medical doctors who are making these decisions.
Probably don't know what they're doing.
So.
And that has actually raised a huge issue that SEPA and others and we're working on as well. And that is because of the controversy and because PANS wasn't being treated in mainstream medicine, it moved into some of the complementary alternative practices, who then started calling everybody PANS, PANDAS.
Mm-hmm.
And so one of the things, you mentioned Medicaid. Arizona, I think because of the partnership between the legislature and the Department of Public Health, they were able to take Medicaid as their exemplar, and they started providing diagnosis and treatment for PANDAS in the Medicaid population, which is 65% of the children in the state of Arizona. So once those 2/3 of the poor children were getting this benefit, then the rich children had to get it as well. But part of that was that the Medicaid required us to meet 3 criteria in order to be treated. One was an accurate diagnosis made by an experienced and recognized practitioner. That's why the Center of Excellence was created at University of Arizona, Phoenix. The second was a measure of improvement, almost like the physical therapist would have to be able to say, oh, we're doing this intervention and they've had 20% improvement, so it's worth it to keep giving them. Or they haven't improved at all, we're going to stop and move to try something different. So a measure of improvement. And then third was a consensus statement that the treatment was effective, which is what our treatment recommendations provided. So they were able to provide all 3 of those to sort of justify this treatment. They also have the financial stats to show that for the insurers, it's actually cheaper to pay for 1 to 3 courses of IVIG than it is to pay for the psychiatric medications and in a single hospitalization, much less multiple hospitalizations over that child's life. So financially it makes sense. Obviously humanly and medically it makes sense. And you asked for the final one, and I think the final one would just be in terms of the Awareness Day, if that can just be something that Georgia is already partnering. I'm looking for Jessica.
We have lots of.
We're not going to ask you to light up the Capitol blue like the autism people would do, but definitely just in terms of getting the word out to those who need to know, I think the legislature is a very powerful body to make that happen.
Thank you.
Dr. Seifert?
Yeah.
Okay, go.
Yes, I have to say, I don't often have a hard time getting my thoughts together to speak it, but I think we all just touched on something that kind of gets my soapbox raised up a little bit, and that has to do with where are we going to bring in parity between mental health issues and physical illnesses, and I think it probably needs to start with changing the phrase mental health. I think that's what people tend to respond to. If I were to say in a room full of people, how many of you have a mental health problem? Most, even if you did, aren't likely to raise your hand. If I were to say in the same room, how many of you could stand to be emotionally better? I think many of us would raise our hands. So, but I guess the reason I pressed the button to make a point, wherever we're going to put this, whether it becomes a part of DSM or other venues, I mean, to me, if we're going to talk about early diagnosis, then we need to get people comfortable with every piece of this. And a great piece of this is the emotional behavioral manifestation of PANS. So however, whatever words allow that to happen, I don't think we're going to get clinicians comfortable with it if we're tiptoeing around the phrase mental health. So as a real quick add-on to that, and then I'll turn my mic off. I will always remember the very first kid that I ever saw in my practice who presented this way. And she was a young girl who had anxious tendencies and an anxious temperament. I had a family history of anxiety disorder. Everything about her presentation to a psychiatrist for anxiety made sense, except the acute onset of the worsening of her OCD. Even the fact that she had OCD, anxiety is an insidious force, and it's a sneaky illness, and it will, just when you figured it out one way, it'll come at you another way, and your brain doesn't care what you call things, it just knows it's chemistry. But we came up with these names, and so an anxious temperament child to develop OCD is also not uncommon. But for the acute onset of it, that was the part that really stuck out, and I'm grateful, that I did my residency at Duke, and I think because there was such a background in research there, this was talked about in residency. I don't even know that every residency program spends very much time on this at all. So all that to say, when this child presented, yes, I was going to treat and make a recommendation for an SSRI because we needed to do something, like you said, put a cast on. That wasn't the underlying treatment plan, though. Treatment plan was let's get someone else involved again, a pediatric colleague of mine, and then we went down that route. And thank goodness that she showed tremendous improvement. She still had lingering anxious symptoms. And to this day, while she's tremendously better in terms of her presentation, she's a young woman, an adult young woman with anxiety. And so we're still treating it. So I guess, again, my reason to chime in is to say, whatever state we're practicing in, we're going to have to get comfortable calling these things what they are. And maybe we start calling them emotional behavioral disturbances related to physical illness, if that fits in some acronym nicely. But we're going to have to get comfortable with this because we can't shy away from the umbrella of psychiatry. Psychiatry has to be an active participant in this condition. While we may not be the front line, we are going to be holding hands with our pediatric colleagues and going forward. So we just need to get comfortable with that.
I so appreciate those remarks. And again, turning to Arizona, since they're far enough away that I can share their stories with you, they did not heed my warning to make sure that a child psychiatrist was in their intake team from the very beginning. They were only open about 6 weeks, and the child psychiatrist sat at the table with them in that very first interaction with the child, because typically, Henry was trying to teach me child psychiatry when I came to the NIMH, so we had the luxury of doing multiple hour interviews over the course of the child's hospitalization, but it was always the back and forth between physical and mental, behavioral, but as you just pointed out so nicely, the behavior comes from the brain, and the brain is only one organ. So it's not like we can, the neurologists and psychiatrists parted for not such noble reasons, and I think it's time we come back together.
Definitely. There's a reason we're all board certified psychiatry and neurology. And then the other reason I bring it up is because it also comes into effect when you talk about coverage and treatment options, because if we're not seen as a part of this diagnosis and a big part of this diagnosis, then when you talk about access to care and getting them the treatment and all that goes along with that, I mean, there's already a frustration about not being able to meet the demands of our communities. This is going to limit it even more. So we just need to, again, we have to embrace it somehow, whatever words make the most sense.
And I like the long way you covered it with that it's caused by a health problem,
behavioral.
But definitely putting it, and I say that only because I deal with my colleagues here, and you were calling it mental health to start with, and just for the students, when you go into mental illness, there's a different connotation in the minds of many of our legislators as we deal with issues down here. But I like the one of putting it together.
Well, I
agree.
hope to be a part of whatever committee starts changing that as well one day. But yes, for the purpose of this, I think it's an emotional behavioral distrirbance related to physical illness.
It's changing. I don't think probably 15 years ago or so you would have probably had a study committee on this issue.
That's true.
So I think we are making progress, as maybe our whole nation is making progress on it. It's just sort of slow
progress.
And how it does is. I know, Dr. Dickerson, you've been waiting forever.
Well, and my questions and comments keep changing.
Okay.
But I think part of it is access to care. I have a blended primary care consultative practice, and so we are looking at the kids with urinary frequency and swabbing them for strep per the recommendations. And these kids don't have fever, they don't have sore throat, they may have lymphadenopathy. We're picking up strep, we're treating it, And so I've had 3-year-olds with acute behavior change, urination on a trip. And it's like, we are treating you for strep. I know that's strep. By the time they get home from their trip, they are feeling better. But then we're having to prophylax because the next time, the sibling gets strep. The problem I have is with insurance is I can present similar patient data, similar codes, and get denied by one company and it's approved by another. So it's like the rules for me keep changing. It's like I keep trying to follow the protocols, trying to make sure I've got the right codes, but one will approve and the other won't. And I don't mind doing a peer-to-peer. But when my peer-to-peer goes on to multiple peer-to-peers because I can't get to the right person, even though a different child with a similar story is already approved in getting the IVIG. And I'm not starting with IVIG, because if I can get an antibiotic and some supplements and probiotics to get this child back, if I can get them access to cognitive behavioral therapy, which is very hard to get and hard for families to afford, I can start an SSRI if we have that, but what I found clinically is you need a much lower dose because it's a secondary process. It's not a primary serotonin deficiency, it's secondary to this infection. But I can do that if I can get all the pieces in a row. But I think that's my concern, is the access. I just need to know what the rules are so that I can follow them for all my patients. And I don't want to use IVIG, but when I need it, we need it, and we need it early. Because I've had a child that could not have clothing on, lost her entire 9th grade year, anxious personality type, very smart, wonderful, fast-brained kid. We got a trial of 3 doses for a year. After the first dose, she was 80% back and was back in school. That's huge. That's huge. And she's still an anxious personality type, but she's on a very low dose of SSRI. She's weaning off her antibiotics. She's in school. She's repeating 9th grade and making A's and B's. That child is different because of the IVIG and the access we got. And so my concern is the kids that when they are, first, we first get labs, the IgG is low because the immune system's gone, and I'm sure you've probably seen this. I can't keep up with an immune system that's gone. I can't have enough antibiotics to keep things away. I can't have enough antivirals, antifungals, anti-everythings to keep that child healthy. And so that's where the early side, before the numbers are completely in the bottom, that's the side that needs to, we just need to boost your soldiers, I think.
So if we had insurance, Richard, I thought, well, you haven't heard this. I thought the problems that my committee faces were horrendous. If you can solve some of these, I'm going to buy you a Superman suit, specially made for you.
Well, we're going to start working on it pretty quick.
Thank you. I mean, the insurances and all of the problems that go with this, that we're hearing in the insurance committee studies and all, they are vast. And I know you're good, so I guess I'm just asking you to be extraordinary down.
Well, I don't know how good, but I've heard this several times today, matter of fact, of denials. You send it back in, you get denied again, or it may take several months, and that that kind of thing is unacceptable. Because if you have to wait several months, and when you could have started treatment in 2 or 3 days, that's a major difference. So we're going to start working real serious on this. This may be my other Achilles heel.
Well, it sounds like to me it needs to be right off the bat put together with an educational program for the pediatricians, and that we need the pediatricians on board with this to start. And when I know family docs do see some family doctors. My husband was a family doc and didn't treat children anymore for years. I don't think a whole lot of them do, but there are those, especially in rural areas, that do still treat children. That one of our first defenses. If we could, if we could get early paid for and early detection, what would we probably knock out? 80% of the cases?
Of PANS? Yeah.
Long, 80.
Yeah. Absolutely.
So-
And actually, Stanford has some numbers that suggest it may even be 90% of PANDAS could be eliminated with early recognition and treatment.
On it. Okay, Dr. Silk.
So how many kids are we talking about?
That's a wonderful
you
question.
You're talking about epidemiology, but it is in terms also for insurance coverage, how much is it actually going to blow up in insurance budget? I mean, is it how out of how many kids that come in with the strep infection do you think are going to end up?
So when we, just a couple of years ago, we lost our orphan status because the estimates are that approximately 1 in 100 to 1 in 200 children, prepubertal children, has obsessive compulsive disorder, and that's from the last EPI study that was done was in the 1980s. So we know that prepubertal children, somewhere closer to 2/3 of those have an abrupt onset. Overall, for childhood onset, which goes up to 18 and includes adolescents, which tend to be girls, it's only a quarter. But I think that the reality is it's somewhere between 1 in 250 and 1 in 400 children per year, so the point prevalence. But it would be a great thing. My oldest daughter now works at the CDC, and I was like, couldn't you just... And she told me that that's actually quite a complex thing to try and make it a reportable disease.
Well, I'm thinking more along the lines of the recommendations for the pediatricians, right?
Yeah.
So looking at the standard caseload for a pediatrician, how many times a year can they expect to see a kid walk in that actually has PANS?
So it actually differs a lot on the season. So I don't know if I mentioned that we had our CVS Minute clinics doing half of their throat cultures for behavioral presentations one year. The next year, they were doing almost none because the strep had mutated and had changed again. We weren't seeing rheumatic fever that year either. So I think it can depend on where you are, but I'm going to let my colleague come up and talk to that because as a pediatrician, she has a better idea of what's going on. There was one study done in 2002 in a 3,000 child practice in upstate New York. They had 12 cases in a year. So that came out to not rare. Yeah.
But wait a minute, we've got one more question. Well, I mean,
yes, sir.
Thank you, Madam Chair.
One last one.
A lot of the comments have already been stated. As she said, questions keep coming up every time someone makes a statement. However, I think that if what I understand, the insurance companies are readily denying the diagnosis early on because of the mental health component. And the mental health is a symptom of the biological dysfunction. And so early diagnosis, public awareness, instructing the docs to get an accurate diagnosis early. Is it feasible that we begin to, once it's diagnosed early, we begin to stick with the biological component diagnosis versus calling it a mental health issue? That's one question.
Sure.
That would be helpful. And the other is how successful is treating the mental health component in resolving mental health issues?
So those are both great questions. The physical component, the point when they still have choreiform movements present, would have the abnormalities on their sleep study, can last for many months. With appropriate diagnosis and treatment, that disappears. So we could, and we have always called this neuropsychiatric. That's just sort of the way it presents. It's both the neurologic symptoms and the psychiatry symptoms. When I was having a very heated debate with one of the anti-PANDAS neurologists, he said, well, you can't call it neuropsychiatric if you don't have any neurologic symptoms. So we marched down the sensory issues, the light sensitivity, the sound sensitivity, the textures. The child didn't wear their clothes because they couldn't stand the feel of textures on their skin. The urinary frequency, the abdominal discomfort that these children get. Adding the Stanford group in, Jenny Frankovic, the leader of that clinic, is a pediatric rheumatologist. And with her clinical observations, she's found that 80% of these children have frank arthritis and arthralgias. So they have new onset of back pain and joint pain and many of the symptoms that we had associated with rheumatic fever arthritis. So that I love the way you summarized it, because that was exactly what we need to talk about this illness as. The second question about how treatable are the mental illness symptoms once it sort of moves into that more chronic, emotional and behavioral disturbances caused by physical illness, but now we're in that component where our primary concern is on the emotional and the behavioral disturbances. They are all eminently treatable. And the wonderful thing about doing this work, is, as you heard, is the children respond 60 to 80% with your first intervention, and then you're only dealing with 20% of the symptoms left. And in our kids, when we would get them to a cognitive behavior therapist, everybody was referred. It is very difficult to find them and to be able to afford the treatment. But when we could get them to a CBT therapist to teach the parents how to keep the symptoms under control during the acute phase, and then to give the child keys and tools to deal with the symptoms when they come back, because this is a relapsing and remitting illness, so they have periods of health. Everybody sort of breathes a sigh of relief, and then they start to come back, and instead of freaking out, you just address those at the point that they're still manageable with CBT. That eradicated symptoms for those children. If we didn't have access to CBT, we had to use medication, could do exactly the same thing. And for a long time, we were using clomipramine, which is a serotonergic tricyclic, but the SSRIs do the same thing. They basically dampen down the intensity of the anxiety associated with the obsessional thoughts so that the child can do their own behavior therapy. And that partnership is beautiful, and the cure rates are in the 65 to 75% rate. That's huge.
Madam Chair, may I just a few other points? Sure. To add to that, because the insurance companies have historically denied claims because they said there's no evidence, there appears to be a growing case of evidence these days so that the insurance companies can no longer claim that there's no evidence. I want to thank you for the work that you're doing in sharing this information. And then lastly, the stories that I've seen, I want to know what is the prevalence of people of color having this disease or disorder?
Those data are a little harder to find because the epidemiologic study was done in a predominantly Caucasian county up in New Jersey. And our clinic at the NIH, people of color were underrepresented compared to what we think happens. Tanya Murphy at the University of South Florida probably has the best perspective on this because that clinic has a good population of African Americans, and what we are finding is it really depends on the origin of the person of color, because if they're from the Caribbean, they actually tend to have a more severe psychotic presentation of this illness. And so that's one of the research questions still under investigation, and it's frankly why I personally am so excited about Georgia coming on board with the consortium and with these efforts, because in Georgia you have the opportunity to answer that question for us.
Thank you. I did say finally, Madam Chair, Delaware, I understand, has passed the law that covers some of the payer sources, Medicaid, private insurance, so maybe we can take a look at that as well.
Yep, you're sitting by the gentleman right there that that's why he's here, to look at this and help us. I have one last question, and I really do appreciate you flying down here and taking time, and hopefully we're not going to make you miss your plane. And I ask you this question because just out of the blue, I get a call from a young man who now lives in D.C. who worked on my first campaign. And then I'd known his parents before that. He's now married, 2 children, lives in the D.C. area, which you said, has a high incidence of this, and didn't tell me why he wanted to have lunch with me. And I said, sure, he had a layover. And I said, sure, Peter, I'll meet you. Well, it turns out that his oldest daughter came down with PANDAS.
Oh, my goodness.
And now 2 years later, the younger one. And so he's very interested in this. And what I don't, is there a genetic predisposition? Because, now one daughter had it and 2 years later, another one. So is there?
Well, that was a great question to finish on because I just put that slide back up there. So the antibiotic prophylaxis, I mentioned that there's only about 12 of the 120 some strains of strep that can do this. In the old studies in rheumatic fever, there was only 1 in 20 families that would be affected. Within those families, multiple children, and there's the literature from the early 1900s is just lovely to read because it's so rich in clinical details. And what Cheadle described was one mom had 9 of her 11 children in the line in hospital at the same time for rheumatic heart disease. Another family, it was 8 of 10 in a tenement building where they had all been quarantined for strep. And so it was like the ideal breeding situation to find out what the genetic susceptibility is. We did a study very early in the course of our research where we looked at family histories of rheumatic fever and family histories of OCD, anxiety disorders, depression, and other behavioral emotional disorders. And what we found was that the children who ended up with PANDAS had an enriched family history of both. So their grandparents had had rheumatic fever, the parents had anxiety disorders, OCD, Tourette's syndrome, which is sort of the neurologic manifestation of OCD, and it was kind of a bad luck of both those genes tracking down. What we're now learning in the basic science side is that all of these systems, the T cells and the B cells, and certainly blood-brain barrier regulation is regulated by those same genes. So they're finding in heart disease that much of the risk factors comes from the immune system, and I think the same thing's going to be found for behavioral and emotional disorders related to physical illness.
So a pediatrician treating a family, children, would certainly
would not be surprised
to, if one child was diagnosed with it, to be very careful about siblings.
Absolutely.
Also, thank you again very much for coming down and being very informative and letting us ask all our questions. Thank you. Dr. Sells.
Good morning. It's still morning. Good morning. My name is Danita Sells. I am a general pediatrician. I founded my practice when I was still a resident at Morehouse. I did my residency training here in Atlanta, and I started my practice in Grant Park in 2006, and we now have 2 locations, one in Glenwood Park and one in Brookhaven. And I'm here mostly, like Dr. Dickerson said, I've had the privilege of learning from my families, and so I just wanted to share some of that experience. So they are here, some of them, so I won't steal their thunder and let them tell their own story, but and of course, I had one opportunity to learn from Dr. Sweeto, taking notes as I'm listening. But I wanted just to share a couple of anecdotes about our experience, and then see if you had questions for me. I don't remember learning a lot about this in residency, but I did see. I started my practice in 2006, and I do remember my first patient looking back in 2010, because she came to me as a patient of mine. Whose mother was concerned about some urinary symptoms, and came in for that, and then mentioned, oh, by the way, she's doing this weird thing with the light switches. She cannot leave a room for the past few days. She cannot leave a room without checking and making sure, is the light switch off? Did I turn the light off? Mom, did you turn the light off? And it's just been, and so my medical assistant had already gotten a urine from her. But I said, well, that's strange. And then somehow it clicked. I like to say that patient was lucky, that something thought to myself, well, I do remember something about OCD and strep. I don't know. And, you're taught to do a physical exam. And she had lymphadenopathy, had pharyngitis. We did a rapid strep. Her strep was positive. Her urine was negative. We treated her for strep. And I remember talking to her mom, and her OCD went away in 3 or 4 days. And at the time, it didn't really seem remarkable. I said, oh, yeah, that happened. That's really rare. That, I'm not going to worry about that. And so I think over the next 4 or 5 years, didn't see another patient to my knowledge. And it wasn't until we'd had a patient who was the second child of a family that we've been treating for a long time, who basically we'd been seeing him develop, was a typically developing child, and really overnight, in hindsight, it was overnight, was a different child. And it wasn't, I do remember thinking, how is this child, he's 6 years old, I think 5 or 6, acting like he's autistic, when if you've been treating this child your whole life, you can see those signs at 6, 9, 12 months, 15 months of age, and we hadn't seen anything. And where is this coming from? And it was from learning from that family and his mother that we are here today and learned more and more and more about PANDAS. And I will let her tell his story. But since that time, that was, I think, 2015, 2016, 2015. So in the past 4 years, we have seen probably 8 or 9 maybe patients from the same community, which is also, I think, alarming and maybe something we need to look at too. Is this a cluster of this particular type of strep in this community? Several patients coming on, and the recognition in my practice now that if you have a parent come to you and saying, they've come to us for the behavioral complaint, my child is doing this. I had one of my favorite stories is I have a patient whose mom called me and said, Sam is having these weird obsessional thoughts about his father. And I just said to her, I said, well, does he have a sore throat? No, but his brother, his adoptive brother, had strep or was diagnosed with strep over the weekend. I said, bring him in. It was a Tuesday, and I remember this because I work with residents on Tuesday, and I had a resident with me who went to see him, and she came in and said, I think he's having, what did she say, something about migraines and blah, blah, blah. And I said, well, what do you think about PANS or PANDAS? And she was doing her infectious disease rotation, and she said, oh, well, we were just talking about that, and they said it doesn't exist. So there is definitely a problem in pediatrics in getting our specialists to recognize this and getting our general pediatricians to recognize this as well. So we swabbed Sam, did a throat culture, it was positive, we treated him and those thoughts went away. And so it is so important that we get the word out to all of our clinicians, to people in schools, to parents, to you know, and as a pediatrician, you're taught to listen to your parents, listen to the moms, and I don't, you know, it's hard. I can't defend all pediatricians in the entire state of Georgia, but I think it's sometimes hard to do that when you're busy and you have 30 patients you need to see, and it's winter and everybody's got strep, and you know, or this child doesn't look like they have strep, you know, and you sort of have these categories of what you're supposed to be doing. But I have learned that recognizing that acute change can make a huge difference. I had the privilege of making a presentation to the Georgia Academy of Pediatrics board meeting in February, and it might be February last year. And I had the room was not very receptive. I hate to say that. And but I did have one of the regional reps from Rome called me a week later and said, I'm so glad you mentioned that to me. I've had my first case of PANDAS in a week, because she just heard that presentation from me, to think and listen to her families and just have the index of suspicion that maybe this isn't just a behavioral issue, but that it has some other source. In addition to strep, we've also seen mycoplasma. We haven't really talked about that, but we have seen mycoplasma be a source of PANS for several of our patients. And again, it's sort of hearing that family mention this, working through that we have an acute algorithm we follow from the PANDAS physician network that all of our clinicians follow. And since we've been doing this the past couple of years, I've actually had families come to me I have a family that comes to me from Columbus. He's on Medicaid and can't find a clinician in Columbus who supports his diagnosis, and he'll get strep and they just want to treat it for a week or 10 days and not do everything, so she drives all the way to Columbus. He's on Medicaid, so getting IVIG is almost impossible. And I will say that you might not have much control over all the insurance companies, but so many children in Georgia are on Medicaid. Right. This is a pediatric illness. So if you can make a change in Medicaid, you'll affect a lot of children. I think it's 60% of children in Georgia or something like that. Yeah. You'll affect a lot of children, make a big difference. We have to do that for all of our kids, but to start there where you do have some influence would make a big, big difference. I just want to look over my notes and make sure I didn't forget something else. So I think getting the word out, talking about the acute change, understanding the benefit of early diagnosis and treatment, and having the index of suspicion in the clinicians' minds will make a really big difference. And we haven't had a huge problem getting our antibiotics covered. It's getting all the other things, getting some of the testing done, as Dr. Sweeto mentioned, and getting IVIG paid for.
I think Dr. Dickerson has
I did, from a mycoplasma standpoint, with Medicaid. Can you get more than 10 days of amycin? Because I cannot get azithromycin, I cannot get
Right.
chlorothromycin. I can't get doxycycline for my kids on Katie Beckett or on straight Medicaid because it's not indicated.
Right.
For longer than 5 days, 10 days, 14 days, but mycoplasma is hard to, it doesn't go away fast, so you need more time.
Right.
So I was just curious what you have found. We've had to rotate, but what do you do?
Well, I haven't had the children I've had who've on Medicaid have all had strep. I mean, it's just sort of been, and we've been able to get it covered. The children I've had with mycoplasma have had private insurance, and we haven't had that problem. So,
I know a lot of my kids with private insurance, we still have to pay cash because they're not going to pay for 30 days of azithromycin, which is handy because it covers strep and mycoplasma, and it's once a day, so compliance-wise, it's a lot nicer too. But private insurance doesn't like 30 days of azithromycin.
But I probably, in my experience, my families just do it. You know, they pay it, and they just
that's
don't
my
mention
point.
it to me.
Right, we're paying cash when, if there eventually could be an indication, it would make that, because not everybody can, and
That's
so
right.
then we're searching for other alternatives that may not be quite as effective as that one, and then it's more times a day, so the compliance, it starts getting a little tougher from a compliance standpoint.
And I have had some issues with, so some of the supportive care we also do are non-steroidals, and there's some evidence that naproxen is better than ibuprofen, both from a tolerance perspective in the child, and I can't get naproxen covered on Medicaid. They just won't pay for it. So my patients take ibuprofen, and we monitor things, but that one little change will make a big difference, and that's one patient. So it's not a huge, I think, burden on the insurance company. I mean, it's one patient in my practice, but I don't. To your point, it's we're not talking about, you know, thousands and thousands of patients. So.
I will tell you that I think that we have a hidden gem that not many people know about. And one of the problems with the legislature is that we pass bills and we have no way to advertise them, like many companies. It's left up to people to spread the word, pediatricians to, if we make a law against about pediatricians and what they do, the pediatricians have to get that word out. So we have what's called, we have a pharmacy called goodpill.org. It's where you go, Good Pill, and you might try for patients who can't afford to get it. It would be worth trying. Out on their website, they have a list of what they have available. It is done on a sliding scale or free. It's reclaimed good medicines, right? And you just send a prescription, and they will fill it and mail it out pretty rapidly. I think they got about a day or a day and a half turnaround. And it's available if a family can pay $1 or $2. I mean, and the fill out form takes about 5 minutes. It's not like buying for Medicaid or something like that. And you might try for your patients. It's not an answer to everybody's questions, but it is out there. And happens to be a bill I passed. I happen to be pretty proud of it. Took me a little time. We passed one bill, do you remember, Richard, and asked our department to set it up. And for 2 years, it just got ignored. We had to rescind that bill and do it with a 501(c) corporation. And so it was a private-public partnership, and they are just really going to town. And we're the only state, I think, that has one statewide, and people can try to get medicines to people instead of having really good medicines destroyed. They're all, it's a pharmacy. It has strict pharmacy, for the pharmacy regulations. They don't take it from medicines from patients, but it has to come from companies that are going to destroy medications and so forth. So you might try that. If you have patients that need any medications that the family can't afford them, they're not on Medicaid for some reason. I'm sure they don't have the expensive thing, but at least you might be able to get their antibiotic for 30 days.
Great.
That's like that. So.
Thank you.
Oh, here we got Dr. Selk. Pardon? Thank you for coming. And really, Richard, I really appreciate you cutting the other one. Who's it? Dr. Selke?
Hi. Actually, I think you opened your practice in 2005 because that was when my daughter was born.
No, it was 2006. because I was still a resident.
Oh, okay.
So she was
So
probably, you
one
know,
of the earliest,
one of my
but,
babies, I call them, original babies. Yes.
Yes, she turned 14 yesterday.
I just can't believe
But my question was, so when you're talking to pediatricians and there's such a deep mistrust of this diagnosis, what has been kind of an effective strategy for you been to talk to people and convince them that this is actually a thing?
It's a good question.
Without discrediting yourself.
Right.
So,
I mean, I tell them about the patients I've seen who get better. I mean, one of my nurse practitioners had a patient and the mother couldn't even believe it. She goes, "How could this be strep?" You know, I can't remember, I didn't see him, but I remember, Chris was just like, he was acting very strangely overnight. His throat culture was positive, and now he's back to his baseline, back to himself. And so I ask my colleagues to think about it. The first time they see this, I mean, it's sort of what happened to me. You see it, and now you see it all the time. It's still small. I mean, I think I can think of, we have thousands of patients in my practice. This is probably 10 or 12 families. So it's still, we see much more just strep that gets better, and they never have a behavioral issue. But once you think of it and once you see it, you can't forget it. And so I just try to tell them that, to think about it. And not really, I think the more complicated is when you have the child who's maybe had symptoms for 4 or 5 or for a long time, and their throat culture is no longer positive. And then, that is a much more complicated situation. And we are, because we are open to it, we're getting a lot of families like that, and we're trying to help them navigate, what to do now that we can't, the chance for early diagnosis is years past. So that's more complicated. So I try to tell my colleagues, you have to worry about those children, but don't worry about it. Does that make sense? Like, you might not feel comfortable dealing with that, but you will prevent that, and that's what we're supposed to do as pediatricians, is so much of our job is supposed to be preventative. You will prevent those children if you can recognize it in your other patients. And so I think that's sort of the controversial part is, and the resistance is, well, I don't know what to do if they don't have a positive throat culture. I understand that. We'll try and figure that out. That's step 5. Can you just do a throat culture? And treat it when it's positive. I mean, that would make a big difference. Okay. Yeah.
Do we have other questions? Well, thank you very much, and to all, and I will say to everybody on the panel, especially to my the pediatricians, thank you for your service to the state of Georgia. To the pediatric psychiatrists, please don't ever leave the state, and thank you so much. We have so few of you. Thank you for that specialty. I know that y'all don't get the big bucks like the other specialties and our pediatricians, and I really think it's a calling. Having lived with my family practitioner husband for so many years, to go into these, but so needed and so appreciated by the patients in our state, and we're trying to do everything we can do to homegrown more, so we can get, especially out in our rural areas. So I do appreciate it. We are almost at 12 o'clock, and then we're supposed to have public comment. Are there any mothers or somebody that came long distance that wanted to speak that won't be back again? That somebody that has a burning that wants to present this time or say something this time?
I can go very quickly.
That's fine. Come up and identify yourself, and that's why I'm asking.
Almost the afternoon.
Well, that's all right. I think people will give you a few minutes over. I don't think they'll get up and run.
So I'm Gabriella Dunny, and I want to thank everybody for being here. And I never get tired of listening to Dr. Sweeto. I serve on SEPA's board, and I'm a scientific advisor for SEPA. I'm also the head of research and development for a local biotechnology company. I don't have experience in immunology, so this came to me because I'm a mother of 2 beautiful girls. One is 16 and one is 11. And this morning I wanted to share my family story in our journey with PANDS actually. And it's truly a personal story of hope, actually, for us. In the summer of 2017, our youngest daughter developed what she described. She came home from a camp, this actually happened in the summer, and she came home and told us, I don't feel good. We're like, okay, what does that mean? She's like, I feel like something is wrong, like I'm doing something wrong. We're like, okay. And truly in a matter of days, she developed escalating psychiatric and physical symptoms. She developed OCD, separation anxiety, severe intrusive and depressive thoughts, along with other symptoms. She wasn't able to sleep. She had urinary frequency, which she actually had before and was always negative. And she, among other symptoms that are kind of long. She was unable to play normally during that period in time. She had fear of dirt. She washed her hands frequently. And because of her intrusive thoughts, and they were very, very specific, she didn't really have a peaceful moment. Her awareness of it, though, was such that she would tell me, I don't know what's wrong, but I wish it stopped. And she went from being an independent, happy child to a very fearful child who really just did not understand what was happening to her. This left stepsister's parents completely bewildered. We just did not understand how in a matter of 2 weeks, and we actually thought it had something to do with that particular camp, which is another story, but we just didn't understand how her behavior had changed so rapidly. She was almost paralyzed, literally, by her thoughts. And as her system got worse, within the first 2 weeks, she begins to express suicidal thoughts. She just really did not like the way she felt. And this is when we reached out to a pediatrician, who is Dr. Sells. Upon careful clinical evaluation and their medical test, our daughter was diagnosed with PANDS, Pediatric Acute Neuropsychiatric Syndrome. Her diagnosis was due to the acute onset of her symptoms in conjunction with her having extremely high levels of mycoplasma IgM titers, despite the fact that she had no physical symptoms of pneumonia or actually being ill. No fever, no cough, nothing. Because of Dr. Sell's awareness of this disease, she received several rounds of antibiotics, and her longest one being a month long, and we were able to pay from our own pockets for this treatment because of the private insurance. And just within the first round of antibiotics, we can see her symptoms begin to subside, and we slowly began to recover our normal child. It has been 2 years since her initial diagnosis, and I'm happy to say that Sienna is doing fairly well. She's had minor episodes, and because those were, her initial onset was treated so effectively and so rapidly, her other peers have been treated with antibiotics and just your over-the-counter anti-inflammatories. It's, as we've heard today, prolonged and sustained inflammation into the brain as seen in these children with PANS and PANDAS, when undiagnosed and improperly treated, can lead to more complex and more expensive treatments that our daughter didn't have to face because of rapid intervention and diagnosis. I am absolutely certain that early diagnosis and treatment made a huge difference in our daughter's rapid and actually stable recovery. She's been, and I think I'm giving the punchline here, but she's been under the care of Dr. Sells since she was very young. And of course, she knew Sienna, and she knew that this was not the normal presentation for her. And I believe our daughter was actually the first case of PANS, not PANDAS, for the practice. And because of the pediatrician's knowledge on the disease and because of SIPA's work in spreading the awareness, she was able to get rapid and successful intervention. And truly, we're here today because our hope is that other children with PANS and PANDAS have the same timely diagnosis and access to care that our daughter did. So I think our story is one of early diagnosis and early success, but I'm more than certain, especially after spending almost 2 years on the board and reading more on the literature, that that made absolutely the impact that it had on Sienna's recovery. Doesn't mean that we're not fearful that it will come back, and she was not in school at the time. So, you know, hasn't been she hasn't been as affected in her school, but certainly that's the goal for what we're here today. So thank you for your time.
Do you mind questions? If anybody has any questions?
Yeah, absolutely.
Any questions? No, I'm glad. I think I can tell you what my first reaction would have been as a parent. I would have been having and probably on my way to the camp to see what happened at that camp that had traumatically impacted my child.
We did, actually.
There we go.
We did, and they looked at us like, you know, but actually what they did is they actually shared her symptoms. She said, well, she can't eat with the other kids. And it was actually, unfortunately, a camp where they were learning how to be outdoors and plant in the garden. The dirt was not helping.
A good option.
Yeah.
So thank you very much for that. When is our next meeting? October 2nd. Okay, our next meeting right now is October 2nd. Is that a Tuesday? That might have to change. Okay, we will let you know when our next meeting. This is getting to be a real problem. It's a Wednesday? Okay. Okay, hopefully that is a Wednesday, you're sure? Okay, that may be okay, then I'll check. Well, if it isn't, we'd do it right away. Is that enough time, a month? Not quite a month for changes for everybody? And sort of. I mean, I don't change it yet. And for our public health students, I hope that if you're still in school and still doing your studies at the time, you might want to follow when the legislature goes back into session in January and follow and see what kind of bills might be introduced, either in health, to dealing with public health, or if there's anything that gets introduced in insurance, to let you find out what happens out of a study committee. And I think it could be a really good learning experience. Sometimes things are very slow at the legislature. We don't solve problems always in the first year. And sometimes we don't get things through in the first year, do we, Representative Bennett? Sometimes you introduce something and it doesn't go anywhere, and you introduce it again another year, and sometimes it takes 3 years. But we get pretty persistent down here and make progress, and then something will happen, miraculous happening, something will get through the first year. You just never know, so it makes it a wonderful, did I say wonderful experience being a legislator? I'm not sure that's quite right, but I wouldn't want to discourage anybody from trying it. So if there are no further questions from the committee, then I would say that we are adjourned. Thank you very much, everybody, for coming. Thank you again. So.